I don't know anything about that. And I still haven't gotten that. So I said, we haven't really talked about it yet. It's a possibility, but
Yeah, you don't know where it's going to go, what people are going to want or need. Yeah.
no. I'm going to see if I can find some more light.
With mental health. When I was in Hawaii, we were actually doing it with soldiers out on the field in Iraq and Afghanistan.
Right.
I mean, they were right in the middle of crap going on, and they would call us and want an appointment, and it was pretty eye-opening.
Yeah.
Okay, what time is it? Almost.
Yeah, we're at 5:57 right now.
So they are going to record our attendance, so we don't have to do it. That's great.
That's what the list of the instructions said. So let's hope.
Yeah.
But I did send out on the email, if they have a problem and they don't receive credit for it, to notify me at least after 7 days if they haven't received anything on their CEU tracker.
Okay.
Ooh, excuse me.
Are we boring you, Lisa?
This is a long day.
Thanks for helping me out this morning, Lisa. I appreciate it.
What did I do? Oh, Gail.
Yeah.
Hi.
I know you can't see me. I don't know why you can't see me. I just have my name there, just sitting in black
You
and
have
white.
to join with video.
I tried to do that originally. Do I have to shut this down and do it again?
No.
Yeah, you can see
Just
me.
hit it. Hit your name.
Just hit my name?
Hit your name, see if that works. Not my name, your name.
Well, that is my name, Gail Steves, right up there.
Hi, everybody.
Hi, Becky.
How are you? How is everyone?
How are
Hi.
you?
I'm doing good. I just was preparing dinner, and then I signed in, and boy, you were all there right away.
Hi, Bex.
Hey, everyone. This is Sherry.
How are you, Becky? I miss you.
Thank you. I miss you, too. Doing good. We're just kind of hunkered down here,
Yeah. How's your mama?
But, we were wondering if she was going to make it through Easter, even to Easter, because she had probably a little heart attack, I suppose. But, being in home hospice, they're not checking her really or, diagnosing or anything like that. So, but then she had a little rebound and she's just got an appetite, back again. And this morning my sister asked her, she was for breakfast, she was having fettuccine with Alfredo sauce, and she loves to have mangoes, right? Fresh mango. But my sister was out of them, so she told my mom, we're out of them. And my mom said, well, that just makes me mad.
I love her. She's so feisty.
Yeah.
She's still got it. That's little Energizer Bunny. Yeah.
Huh?
She's the Energizer Bunny.
Yeah. Yep. She's definitely, hanging in there. I think the Lord has a purpose for her to stay here a little longer.
Absolutely. Yeah. It's all in his plan. Mm-hmm. Oh, gosh.
Thank you very much.
Leanne, it showed 6 o'clock. Did we want to start or we want to give them a few more minutes?
Well, Susan's going to start. So whenever Susan wants to, we have 42 people in the room with us right now.
Whoa. Hi, everybody.
Wow.
Not in this room, but in this room.
Oh, in the room where you are?
Yeah, we got them crammed in here.
Social distancing.
I can only see like 6.
Put them a dust up while they're there.
Yeah, we got 45 now.
All right, we'll start. Hi, everybody. Welcome. And first of all, I just want to say I hope everyone is safe and staying healthy. And we're all in this together. And don't forget to wash our hands.
Yes, ma'am.
And I want you all to know we're making history right now. We've never had a virtual meeting. This is the very first one for our chapter. I want to thank Leanne for that and all the other people that have helped her with putting this together so that we didn't have to miss another meeting. So I just very briefly want to tell you a couple things. First of all, the May exam was canceled. And the June 13th exam, I'm just going to tell you, watch the website. We're not sure what's going to happen with that, or depend on if the school's going to be closed or open, if we are able to find another site. There's a lot of variables, so just watch your website. We will give about 30 days notice for that. The May meeting, we'll have to get back to you also on that. So watch your website for that too. It may be virtual, it may be canceled. We're not sure, but we will let you know. And also the April review class, as you know, was canceled, but the October 17th review class is on schedule. And yes, Leanne, I'm going to get my questions into you.
Yes, Leanne, I will too.
I'm compiling all the information right now so that everything's ready to go for October 17th so that we can help you prepare for your test. The AAPC new members and new certification examinees will be recognized at our next meeting when we all get together, and we'll celebrate then. But up until then, we just want to thank you very much for being part of this historical moment in our chapter. And I want to turn it over to Leanne now and just thank her for preparing this great informational, educational opportunity for us. Telehealth and telemedicine, you've heard a lot about telemedicine lately. And we were just discussing, do we think it's going to stay with us after this pandemic is finished? I think so. But, you know, we'll just have to hang around and see what's going to happen. But I think it's going to impact all of our lives a little bit more in the future. And also she's going to talk about resumes and interviews. So hang in there. We're going to have her talk for a while. And as you drop off, all of your names will be recorded. Give a couple days to AAPC to record it into your CEUs. If you don't get in touch, if you don't see your CEUs in a few days, give it about 3-4 days, then get in touch with Leanne or AAPC, and we'll take it from there. Okay. Bye, everybody. Thank you. And let's have a good meeting.
Bye, Susan.
Great. Hey everyone. So I'm Jackie. I'm Leanne's daughter.
Hi, Jackie.
AKA tech support. So just a quick Zoom orientation. If you haven't used it, there is a chat box on the bottom. It seems like everyone is finding it. If you have any questions, just post them on there. Presentation, and we will try to get those answered as quick as possible. Everyone should be able to see the presentation right now. If at any time you can't, just yell at me, say that you can't. And then also, I'm going to go ahead and mute everybody so there's no background noise. If you have any comments and you want your microphone on, you have a button at the bottom to unmute yourself. So, all right, we'll go ahead and get started.
Hello, everyone. My name is Leanne Altman, and telehealth, as we know and work with it today, is different in the face of this public health emergency than we prior know. The rules and regulations that were once put in place are now kind of being bent a little bit to provide care for those in need during this difficult time of uncertainty that we've all come to recognize. So let's start our presentation with the telehealth and telemedicine.
Maybe.
There we go. So what exactly are telehealth and telemedicine? Well, if you're familiar with telemedicine, it's when a referring physician and a consulting physician consult using electronic communications between one another. Telehealth is when a patient and licensed healthcare provider will interact using electronic communications. A lot of providers right now are currently using telehealth. That includes their two-way, real-time, interactive, secured, and HIPAA-compliant electronic audio and video telecommunication systems. But as we know right now, they're kind of waiving the HIPAA compliance right now underneath the waiver 1135. It must be provided, of course, with an approved telehealth or telemedicine equipment or communication. And it is giving evaluations for telehealth that are non-face-to-face services, typically in response to the patient's online inquiry or a phone call, and are used to address their non-urgent, ongoing, and new conditions that they may be seeing. With the telemedicine, that is all still the same list of information. The only difference is it's used by a referring physician when in-person, face-to-face contact with a consulting physician is not physically available. So the referring physician and the consulting physician can communicate via computer or Skype or telephone or internet. They can use any of the capabilities that they see fit to communicate in regards to a patient's health. So this is why it's so popular right now. COVID-19 is considered a global pandemic. Right now, not all the patients are immune. There's a fear of contracting it, the reports and the fear of death. There's been a very large increase in patients with anxiety that we're seeing. A lot of them are very scared to even leave their house. They send neighbors or they have stuff delivered. Certain providers are forced to close their doors due to exposure. They're now quarantined because either maybe one or two employees may have contracted it or came in close contact with someone that has COVID-19. There's orders of stay in place that are put out by the governor, president, things like that. The waiver 1135 does kind of help in this epidemic that we're currently facing. There is a need to communicate during this uncertain time that we're seeing. So we'll discuss a little bit about COVID-19. I'm sure everybody knows you should be washing your hands and singing your happy birthday song or the song of your choosing. Most of the people are being required to wear face masks at their employment when they go out to anywhere in the public to go grocery shopping or run any essential errands. They have slowed down a lot on flights and air traffic control only because of spacing on the airlines, and a lot of people are not allowed to travel out of state. And then once they do get out of state, they have to quarantine for 2 weeks, and a lot of passengers don't want to do that. They want to get off the plane and enjoy where they're at or deal with business right. They have a stay in place. You should be staying at home. You shouldn't have close contact to where that you're shaking hands a lot of people or hugging. You should be touching elbows or just greeting or doing a virtual wave to each other. Using hand sanitizer or even possibility of using any antibacterial soaps, antibacterial products, using Clorox wipes, using Clorox and bleach. There are mixes that they will tell you about online you can access. And of course, everybody's favorite, social distancing, staying at least 6 foot apart, even though my little diagram of the other 3 people should be not in that group. They should be a lot further apart. So for waiver 1135, there is a link at the very top that would give you some great social reading if you want to go ahead and review it. And so you understand a little bit more as it applies to you in your everyday workflow. Some of the things that you will see is where they waived physicians to go from state to state without having to be fully credentialed. That was a possibility. They were allowing for, once hospitals are full, that the overflow can be sent to another facility where it might not necessarily be a hospital, but can be set up as a makeshift hospital. So the purpose was so that the sufficient healthcare items and services are available to meet the needs of Medicare, Medicaid, and CHIP beneficiaries. Also, that healthcare providers can provide such services in good faith and can be reimbursed for them, which in such order is telehealth, and not subjected to sanctions for noncompliance and absent of any fraud or abuse. Now, we've heard CMS state that upon receiving claims for telehealth, that they will not go back and do an audit of everything that was sent in and scrutinize it. But just be prepared that anything is possible, and CMS could very easily and very quickly change their minds and say, well, there's been an mass amount of claims, and they would like to review some, if not all of them. So the duration that they're stating and that they put in place for the waiver 1135 is that the duration ends no later than the termination of the emergency period or 60 days from the date the waiver modification is first published, unless the Secretary of Health and Human Services extends the waiver by notice for additional periods for up to 60 days up to the end of this emergency period that is currently happening. So, performing telehealth. Who can actually perform it? Well, I have a few examples that are on the screen for the specialty cares that can. These are most of the ones that I deal with on an everyday basis. Primary care, rheumatology, cardiology, nephrology, pulmonology, endocrinology. Those are my top ones. But the ones that can actually provide telehealth are your MDs, your PAs, which are your physician assistants, your nurse practitioners, your nurse midwives, your certified nurse and anesthetist, clinical psychologists, clinical social workers, registered dietitians, and nutrition professionals. This list is available, of course, on CMS website as well. So what this is the patient is communicating via their smartphone, their computer, or any other video audio device that they may have, their iPad, their cell phone, computer. Some of those that have flip phones might not have those capabilities, because some of the seniors may have still things like their jitterbugs and stuff that is supplied to them. And the physician then evaluates from their exact location, whether it's in the office, their home office, or even out and about in a personal location where they use smart technologies with video and audio or just audio alone to communicate with the patient. So the audio and visual call, or just the regular phone call, is made by the provider, and the provider evaluates via audio visual, and of course then documents the appointment. That is the most important thing that can happen, is the documenting of the appointment. So first and foremost, my little phone tells you exactly the very first thing that should be discussed and documented. Getting verbal consent. That is very important. The next thing should be the reason for the appointment, if any other physicians are treating the patient, if there's any medication reconciliation or changes, of course, the test that might have been recently performed that the patient wants to go over with you, any labs, of course, or recent hospitalizations. Especially during this public health emergency, recent hospitalizations is very important. So this is how we bill for these services. There are eligible CPT codes. As you can tell, we have 3 sections during this pandemic that are our most common. The 99201 to 99205, of course, is a new patient visit. They stated we could still do new patient visits during this time. That is through audio and visual, where 3 of 3 components, of course, is required. The next is the 99212 to the 99215. If you notice, 99211, which is typically a nurse visit, because nurses cannot do telehealth, has been ruled out. Now, that doesn't mean you can't bill it if there's not enough documentation when you code it out accordingly and you only have just the 99211. And that falls under the audio and visual category also. Then, of course, there's the audio only, which a lot of patients do prefer sometimes, which is the 99441 through the 99443 series. It requires exact call time documented, the call reason, the discussion documented, the assessment and treatment of the problem, and whether the patient, they cannot be seen within 7 days prior or within 24 hours after, or upon the next available appointment for them to be treated for this issue. And of course, it is audio only. So when you're billing the audio only, this is a breakdown of the minutes. It's the 5 to 10 for the 441, 11 to 20 for the 442, and 21 or more for the 443. This is where this must be documented in order to bill it. If it isn't documented, then you cannot bill it. Your doctor or physician, PA, NP, whoever is providing the service must document it somewhere in their note how long they spoke to the patient. And it has to be actual time or a total amount of minutes. And it cannot say something, I spent a greater than 22 minutes on the phone with patient. It must have pretty much the exact time that they were on with the patient. So with Medicare, I don't know how many of you were on during the presentation that they originally had for telehealth after the waiver 1135 came into play and everything kind of happened with the situation. But Medicare first stated on March 19th that we should be using modifier CR, which is the catastrophic disaster related modifier with a place of service of O2. Then on 3/24, which was exactly 1 week following to the day, they stated no use of the modifier CR and place of service O2 was still registered to use. Then on 4/7, they came back and they changed everything and said, no, we would like to use modifier 95 with a place of service of 11. Now, the difference between that place of service 2 and the place of service 11, place of service 2 will pay at a facility rate when you bill. Place of service 11 will pay for full reimbursement just as if the patient is standing in front of the provider and being given services on a face-to-face basis. That is the big difference that Medicare wanted to make sure was a main impact for physicians, was that it was kind of during this public health crisis that they were not changing the rules of the game as when telehealth is originally set forth and billed. So now we feel that we're kind of on the direct path with Medicare now. And if any of you that drive 17, you know you love it when the cones are gone. So as of right now, what we know with Medicare are these things: that we can do phone calls, audio only, with the 99441 to 99443, but exact time must be documented by the provider. We can do audio and visual, which is 99201 to 99215. We also would have to bill each one of those telehealth communication visits with a modifier 95 and a place of service of 11 rather than O2. Now, the next two slides that we have, of course, are charting our most popular payers. The first one is audio and visual visits. And I want to give a big hands out and awesomeness credit to Gail Smith, who sat and did this and went through all of our providers that we deal with on an everyday basis. And as they changed everything, she updated these spreadsheets for us in our office so that when we were billing, we knew exactly what we were doing and how to bill for it. And if one change came down the pipeline, she was ahead of the game and was like, we have to change this now. But these are our most popular payers, which is our Medicare, our Blue Cross Blue Shield of South Carolina, Cigna, Aetna, and United Healthcare, including their Medicare policy plans. With them, you notice that they all want that place of service 11 now. They all want the 95 modifier, and of course the eligible CPT codes that can be billed for the audio visual visits. And then of course the next updates that'll be sent out either via email or put on their website. And the next chart, of course, is just the audio visits. It is replication of the same pretty much for the primary. The only few differences is with Blue Cross Blue Shield of South Carolina, for the audio visits, they do not want any modifiers applied to the procedure codes 99441 through 99443. And Cigna and United Healthcare, even with the audio visits, even though there's no visual, they would still like to see regular E&M visit codes of 99201 through 99215. So let's look at some sample documentation between the providers and the actual patients that are doing telehealth. So the first, of course, is history component. Because as you know, when you're doing telehealth, your exam piece is going to be a little bit lacking. It's not going to be a full exam because the provider cannot reach through the phone or reach through the computer and actually assess the patient on a physical basis. So the history component, especially with established patients, they will, with the established patients, you only have to have 2 of the 3 components. With the new patient visits, of course, it follows the same CPT guidelines. You have to have 3 of the 3 components, which means that you might not have your providers getting a level 4 or a level 5 that easily. But with these history components and the exam components, we will show you a couple examples of exactly just a little taste of what your providers can do in order to at least fully extend and get that higher level of a 3 or a 4 rather than the 1s or the 2s. So here at the one example, of course, is the history component. And don't forget to obtain a review of systems and an update of past family and social history from the patient. You kind of especially want to find out from the patient, have they recently been to church? Have they recently gone to Walmart and been in there for 4 or 5 hours shopping for stuff, looking for things that they couldn't find? Because that increases their risk of exposure to COVID-19. Has the patient recently been to a birthday party where maybe one of the other attendees found out that they were positive for COVID-19 or they were asymptomatic? It is a big risk to some of the patients, especially the elderly or the ones that have a low immune system. So with the history component, I hope you'll have all had a chance to read this, and just to let you know, all slides will be fully available after the presentation also. So this is just a breakdown of the exam portion. These are just a few little examples that we have actually seen within our own records. Constitutional, of course, you can always tell how a patient is. They can always tell you whether they've gained weight, lost weight. And it's also kind of not really been confirmed by CMS to date. We did introduce the question during one of the audio conferences, but we've not had a fully confirmed response back from them that states that the patient can do their own vitals during an audio visual visit and show the physician their BP monitor, things like that, their temperature, their thermometer, things like that, and we add that in as their constitutional to qualify. Of course, you can find out their psychiatric portion. A lot of patients right now, like I said before, they're anxious about the situation. They're having a hard time dealing with this. Maybe they have another family member that's in their home that is also anxious and maybe, giving them a little bit of anxiety themselves that they might not have experienced before. The eyes, you can tell certain things with the eyes, whether or not, are they swollen? Are they red? Are they bloodshot? The physicians can see that. Musculoskeletal, they can do range of motion exercises with them, like having them hold their arms out and move them in circles. They could stand up and have them walk back and forth in front of the camera. Things that pertain to that, if they can stretch, one side to the other. Skin, they can tell whether there's rashes, lesions, if their nails are turning different colors. Ear, nose, mouth, and throat. This is one that everybody's kind of on the fence about. Now, of course, if they open their mouth and they stick it out during the camera, you can see whether or not some of them, they'll have mouth sores or lip ulcers, things like that. So you can see kind of into the oral cavity. Now, the ear portion, you can't really tell how the patient's hearing, whether or not they have impacted cerebrum, and you can't see all that through a camera. Then there is also the nose and the throat. That's also kind of a tricky one too. It has a lot of people on the fence about whether or not we can count this because there's certain ways that you can have it look and tell, and then there's other ways where you absolutely cannot. Then your medical decision making. This is kind of like your steak and potatoes of the meal. This is like the main course. So you want to make sure that your physicians are putting into their documentation if this is a new problem, an established problem, worsening, stable on their current regimen that they have, if it's well controlled, chronic or acute, all that stuff that's listed there. You want to make sure that if they are listing that they're hypertensive, that they're stable on their current regimen and they're not going to change any of their medications. You want to make sure that your physician is stating that. If the physician states during this time that the patient is experiencing a large amount of anxiety, they want to add a new prescription to their regimen, but something that will calm them a little bit, but not cause prescription problems later on down the line for other stuff that they have and that they're currently taking. If they're changing their current dosage, discontinuing something, if they had any new radiological tests that were ordered that the patient went to before this public health emergency, and they want to go over those issues. You want to make sure that your physician is documenting that they went over their patient's last x-ray. They went over the patient's last MRI results with them, because the patients are going to feel not only anxious to get those results, but they're also probably just feeling anxiety because of everything that's going on, or even depression at this point for being stuck in their houses for a long time. The last thing, if the physician wants to send the patient to the ER, say they're on the phone with them and they can hear through the phone or even through audio visual, they see that the patient's struggling to breathe or having issues in the patient's home by themselves, the physician may state, let me call an ambulance for you and have them take you to the ER, or if you can, possibly drive yourself to the ER or have a neighbor drive you for sake of it, just to get a full checkup and make sure that everything's okay during this situation. Any of that needs to be documented. Right now, the biggest thing I know that physicians are going to give the pushback on is there's so much documentation. Why do I have to put so much stuff in there? Well, right now we're kind of not wanting to sit and give you a 1 or a 2 or a 3 when you may be, prescribing, doing new issues with the patient, discussing more further things with them, and you want to make sure that your documentation constitutes at least a 3, a 4, or a 5 if necessary. If it's medically necessary and it's documented as medically necessary and everything is in place and where it's supposed to be, they should qualify for that. Right now, the biggest thing is communication between their patients and their physician is the biggest thing. It's key even during this pandemic. The patients want to make sure that they can still get in touch with their physician and discuss things, even if they are minute to a physician, they may be major to a patient, especially during this public health emergency. Some of the things that I would like to add is that Medicare always has additional information on their CMS website, including a provider fact sheet that also gives all details that are listed for anything new updates, some of which has a little bit to do with billing. They also have a full list of the telehealth billable codes. So if the codes that we discussed today are not exactly the codes that you would typically bill for from your office, say you do dialysis, there is certain billable dialysis codes for telehealth. But that full list of telehealth billable codes that are accepted with CMS is available on their website. TRICARE at this time, from what we're seeing, what we're reading, is following Medicare's guidelines. So they're following that place of service 11 with the modifier 95 applied to the audiovisual codes, which is the 99201 through the 99215. And they're also following with the 99441 through the 99443. We've not seen anything that has come back and stated that there would be a problem with that, but we also don't have a very large amount of TRICARE patients at this time that we're noticing that are receiving telehealth. And also with anything, if you want, you can always look up the 1135 waiver. It is a large amount of paper on some of the ones that you will look up. Some of them can be anywhere between 30 pages all the way up to 50 some pages, depending on what website that you download it from or look it up on. And I'm sure everybody has also noticed that they have added the new diagnosis for the COVID-19, which of course was the U as in unicorn, 07.1, that has now become effective as of 4/1/2020 from the original effective date that they were going to enter it as, which was October 1st, 2020, when the new ICD-10 will be published and put out. So now, if there are any questions in regards to anything, we will open the chat box and see if there's any questions that we need to answer currently.
So we just had the one question about information being available. Just copy this email address down and send us an email, and she'll send the slides and everything back to you. So.
Any questions?
I have a question. So on the news, you hear that everything is at no charge to the patient. Is that really true?
Actually, we have heard it on two different ways. We have heard that it is when you bill it a certain way that some of the insurance companies will go ahead and waive the copay, coinsurance, and deductible portion to the patient. Most of the insurances that we are seeing, though, no one has actually physically published anything that says that. It does state that if it is a positive, confirmed case of COVID-19, that they should be waiving that if the appropriate diagnosis is applied as the primary diagnosis.
Thank you.
You're welcome.
I have a question about Blue Cross Blue Shield.
Yes.
We do not have a telehealth agreement with Blue Cross Blue Shield, but it's my understanding at this time we're still allowed to bill I think they 99441 and now E&M codes for, I guess, the next month. I just want to confirm that was everyone else's understanding of that as well. And has anybody applied to do the Blue Cross Blue Shield telehealth? And if so, how bad was the process?
We actually, our company as a whole, did apply for the telehealth through Blue Cross Blue Shield. And it wasn't that bad of a process that I thought. We filled out the applications rather quickly. I want to say over the course of 2 weeks, continuation of discussions with our credentialing department. And they only had one thing that we didn't pick on the paperwork that they sent back to us and asked us for. But other than that, it was pretty simple. There is a link on Blue Cross Blue Shield South Carolina website within their education section that discusses telemedicine versus telehealth and the virtual care. They send everything out and they have all the forms there.
I'd like to add as well, I did mine last week. I sent the application in on Tuesday, and I did not get a response. They told me it would take 2 to 3 days. Friday morning, I did send my contact person an email, and she emailed me back that afternoon, probably a little after 5, and said I had been approved and that if I would just hold my claims until that following Wednesday, everything should go smoothly. I've actually emailed her one more time with an additional question, and she got right back to me. So the process is fairly quick, and they do deny the claims if you do not have that application submitted and approved.
That is correct.
Yes.
Okay, thank you. Did you guys already have a telehealth policy in place?
I actually had to generate a policy, 2 different policies, and it took me a matter of a few hours. I was a little caught off guard by having to do it, but I pretty much ran through it and submitted them that same day. So it went, like I said, relatively smoothly.
Okay, thank you.
You're welcome. Thank you for the question.
I have a question. Is anybody doing antibody testing, and do we have a code for that?
Okay. Gotta ask a hard one, Susan.
I'm just,
We ordered the antibody testing, but it is not in yet. And I do not have the code with me, but they did provide it, the company that we are attempting to order this from. And from my understanding, it's being covered by almost every carrier.
Yeah, that was the information that I heard, that it was being covered by almost every carrier. But I do not, in my paperwork, I do not have the antibody code at all.
I can speak from the pharmacy perspective that the antibody testing has not been shipped out yet, and that's still an up and coming thing, so it's coming. The pharmacists are excited.
no, I just wondered, when they said it's being covered, if they come back negative, I'm just wondering if that's going to be covered. That'll be interesting. Thank
Yeah.
you. Thank you.
You're welcome.
LabCorp told us that they would have an antibody test available by the end of this week. Now, that doesn't mean it will be available by the end of this week, but that is what LabCorp is telling us. They have not provided me personally with any of the information yet, so I'm still looking out for that to see, what's involved with it, what they're testing for, who it's going through, et cetera. I don't have any of that, but they said that we should have a test code and everything we need to order it by Friday or Monday.
From what I heard on TV yesterday, I didn't hear it today, but yesterday, the experts were discussing the fact that the antibody tests weren't perfected yet. So they were hesitant to send a lot of them out. So just wanted to pass that by.
Are there any other questions? Yeah, Gail's jumping in. Gail jumped in there.
Hold on one second.
Okay, so the antibody code that is coming up for the antibody test is 86328.
And that's in the chat box. Thank you, Gail, for that.
Welcome.
And what we received was a question that says, have you seen anything from CMS regarding the providers being able to use only the medical decision making to select the level for the visit? Because this was introduced through the CARES Act. The response to that was, coverage will depend on the diagnosis used. The CDC website has a guidance of the list of codes that can be used.
Actually, I unmuted myself.
There you go.
I was answering the other question regarding the coverage for the antibody test.
Okay.
CDC has got a list of not just the U07.1 code, but the screening codes that you can use for it. As far as using just the medical decision making for your leveling out your visit, you can do that. That is part of the CARES Act. They do want provider. You can focus on that, but remember that's only for Medicare. For all of your other payers, including Medicare Advantage plans, you want to make sure that you have the other elements, and you still want to have that. You still should have a strong history element for your telehealth visits, simply because that's going to be where your medical necessity is. That's going to be where your, medical malpractice is going to focus on if anything happens. You know, they're going to say, well, you didn't get a good history. You did this medical decision making. So you still want to have your documentation illustrate the medical necessity from the history portion down to the MDM. But that's where you can go back to your doctor to maybe amend the record if you need to add to that history portion. That's all.
Mute.
Sorry.
Oh, sorry about that, everybody. We are muted. That was tech support's issue. To answer Lana, using the U071 be the diagnosis, or do we need a rule out code? The U071 is when there's a confirmed case of the COVID-19, from my understanding. Any other of them where we are testing or ruling it out, of course, it would be the diagnosis itself, whether it's pneumonia related, shortness of breath, things like that, and you can use a rule out code for that.
Are there any other questions before we move on to a little bit of resume building?
No?
All right. Let me make sure everybody is muted. Looks like it. Okay. All right. So I'm actually going to cover the resume part. So hold on. I have a chat box in my way. But so just basics, resume versus a CV. I know I'm more in the professional world and we see a lot more CVs than resumes, but the key difference is the purpose. So your resume, you're trying to catch the eye of recruiters or hiring managers versus the CV where you're providing literally everything about your life, what you've done, what you've education, conferences, like everything. It's super long. The difference in content, so your resume, you want it to be short and more of a summary versus that CV is a lot longer. You can even see like paragraphs on them and they're very detailed. And then length, so CVs are meant to be shorter or resumes are meant to be shorter, about 1 to 3 pages, and the CV has no restrictions as long as necessary. I know mine currently, I'm in my last year of college and mine's already 8 pages long, so they can get pretty crazy. So where do you start when building a resume? You want to gather all information that's going to be necessary. So no like specific dates for past work and professional experiences. Your references contact information usually includes like an address, a phone number, and an email and their names. Education experience and skills relevant to the job that you were trying to get hired for, or general skills if they're good for any job. You want to read all requirements of the job description. Make sure you know if they require like a cover letter, how many references, what the interview process is, stuff along those lines. And then try to avoid templates when creating a resume. So Word is very tempting. When you type in the word resume, like on the first line, it'll give you a whole template. And a lot of those templates can be frowned upon from employers because they're not unique. You want something that is built from you for the purpose of highlighting like your experience versus just something that Google and Word created. Know when the deadlines are, so that goes with the requirements. Just know when you need to apply by, when your interviews are going to be, and et cetera on that. So key components, you have your personal contact information, your summary statement, skills and qualifications, work experience, professional experience, education, and references. So I'm just going to go through these in a little bit more detail. Your personal contact information should have your name, your credentials, your phone number, email, your primary address, and your LinkedIn profile if it's applicable. So, and I have two different examples here. This one is more of like a vertical format, and then this one's on the right is more horizontal. So you could use either of those, whichever you prefer. Your summary statement is also known as the resume objective. It's a short and concise overview of what you have to offer. It should be roughly 3 to 4 sentences. You don't want it to be super long. You want to try and use some adjectives that make you stand out. So saying like you're highly skilled in something or professionally trained, having a solid foundation, or saying that you're dedicated. Then I just have an example above. All right, so we have skills and qualifications. So typically a bulleted list, it can be listed in one line. I personally think that it's a little bit more jumbled and it's easier to read a bulleted list. So your skills should be relevant to the job and include your credentials, which should be listed first, and that's in order of importance. So you've worked hard to get the credentials, so you want to highlight those and put them first in order, and then maybe get down to some more basic skills such as Microsoft Word or medical terminology, etc., like confidentiality on that. Then we have work versus professional experience. So I know commonly these two words can be used interchangeably, but there is a slight difference. So your work experience will include all prior and current experience, including a brief job description. If you have a lot of experience in the work field, you want to focus on, say, the past 10 to 15 years, just so it's not super lengthy. And they want to see stuff that you've done recently, kind of like what's fresh on your mind. And then professional experience is going to be more like going to conferences, if you've done research. And a thing to note is that not everybody will have this professional experiences category, and that's okay to not have one. So we got education next. Should be in reverse chronological order. So you want to start with your most recent and work your way back. You want to use relevant education, so any degrees in progress, and then high school. Mostly you want to list high school if that's your only prior education experience. So say you're more of a recent grad, then that's okay to put it on there. But once you've obtained some degrees and certifications, you'd want to put those as priority and probably drop off the high school. What to include for each of those, you want to have the name of the school, the location, the degree obtained or in progress, and then your dates of attendance. Could be very specific to the day, or you could just put the year. So references is the last big section on there. And I know a lot of people like to put available upon request. I think that's a safe bet. You want to gear your references towards, say, the job itself. If you're going, I'll use my example. So if you're going for another pharmacy, you wouldn't want to use references of, say, a restaurant that you worked at. You would want to use coworkers or a boss at previous pharmacies that you have worked at. You do want to choose wisely, though. Some people can get called on for references, and they will be brutally honest. So you want to try to avoid family, close contacts. Use someone reliable and someone that really respects you as a person and can speak about your work ethic. You want somebody who's going to say that you're a hard worker, you're going to be a good asset to this company. And you don't want somebody who's going to be honest and say, well, this person was late every single day, or this person never worked on anything throughout the day. So general formatting, you can use the 1/2 inch margins. You could also use the 1 inch margins. It really depends on spacing and kind of what you want it to look like. They do recommend Times New Roman, size 12 to 14. You don't want to go smaller than 12. It doesn't look good necessarily, and then the font can get really small, making it difficult to read. Bold your headings and your name. So you want to bold things that are important, that are key highlights, and distinguish like separate sections of the resume. And then I just put this bullet on here about how to find a horizontal line on Microsoft Word. When I was doing this, I was struggling with how to put a line on the document, and this is how you do that. So just a little help for anybody else who would like it. And then this is my example. Here's the horizontal lines that I was talking about. So this is just a general one-page document, and it has everything that you would expect it to have in a shortened version. And then that was the end of the resume portion itself. I'm going to pause for a second and see if anybody has any questions just about the resume. Okay, I think we're good. All right, so moving on, just 2 short things. So I have the cover letter, which may be a requirement. I would say, even if it is not a requirement, to just go ahead and turn that in with your resume. It makes you look more dedicated and that you really put effort into wanting to be hired for a job. So your cover letter gauges more of your personal interest, makes you more memorable. Again, similar to the resume, you want to avoid templates because this truly is all about you and all about how you want to sell yourself. And templates don't really do that. Templates are just basic. They say that you're organized, you work hard, and that you're detail oriented. So you want to try and be a little bit more detailed than that. Include some work history, professional skills, and your interest. These hiring managers want to get to know you personally, because when you work with them, they're going to get to know the ins and outs of everything and not just what you're putting on paper and saying that you are. They're going to find out all the other small details down the line. And you want to keep this to about 1 page as well. And then once you have an interview, we'll have a little post-interview. You want to follow up about 1 week, if not told otherwise, during the interview process. And then you want to make sure to send a thank you letter or card to everyone who is involved in the process. And email is okay, but handwritten cards are more preferred. So even at the end of the interview, don't be afraid to ask for information of who you could send information to later. So get an address, get an email, or a business card of your interviewees. All right. So I just had questions, and then I pulled this slide again if anybody needs this email to get a copy of these slides.
I just wanted to add something to the interviews.
Uh-huh.
I've done a lot of interviews in my career, and a couple things I just wanted to add. Don't put your social security number on your personal information. You would not believe how many people do that. It's not necessary. If you get hired, HR will get your social security number. But a lot of people do that, as well as their birth date. If they really want to know how old you are, it'll be obvious as they go through some other information in the material. But don't put those 2 things at the top of your resumes. The other thing is, it's really surprising how many people lie on their resumes. There are people that every day get fired because they lie or exaggerate to the point of lying on their resumes. Even if you're hired and they go back and look at a resume, they can fire you for that, or an application. We want employees that are honest. We want employees that have good business ethics. So, you know, don't be that kind of person. We know you're not. So just keep that in mind. Thank you. That was great. Thank you.
You're welcome. Is there any questions, any more questions on anything that we've presented or shown you this evening? I don't see or hear anything.
I think the presentations were excellent. I really want to thank you both for all the work that you did putting this together. Not just the presentations themselves, but the whole dynamics of putting them on for us and putting the whole Zoom thing together. I want to thank all of the participants for participating. You know, it's not a meeting without all of us getting together. Hopefully we'll get to do this more. And again, like I said, you've been part of history today, so we should feel good about that.
Yeah, we had a total of 59 in
Oh,
the meeting.
wonderful. That's great.
Yeah.
Great. So if you have any feedback on that, please give that to us. You can give that to any of the officers in writing on our emails. Those are on our websites. So thank you so much. If there aren't any more questions, we'll adjourn, but we'll leave it open for a few more questions. We'll leave the chat group open and the microphones open for a couple more minutes. Again, thank you to everybody. And
Okay.
maybe
Susan,
see you-
I have a question.
Yes. Hi, Mary.
Yeah, this is Mary Haney. I came into the meeting a few minutes late, so how do we get a register for our CEUs?
The AAPC is going to register you and give you automatically your CEUs. If you don't see them in about 3-4 days, then contact Leanne or any of us and we'll take it to the next step. Okay?
Okay, thank you so much.
But give it a few days.
Okay, Susan, it's great to see you.
You too. Thank you for coming. How about feedback on the way this was presented? Did you like it? Was it easier?
Sorry.
Do you want to see more like this? We can do 2 a year like this. 2 meetings a year like this.
I think it was a great job. I think we had a lot of people that were interested in this. There's, you know, still 57 people on the screen right now. We've been having a lot of people that come to our meetings, but a lot of them are with the students. So this is maybe a nice way to get those people that can't come out to our meetings involved. So doing 2 a year like that might be a nice thing.
We're getting, I don't know if you guys all have your chat boxes open or not, but we're getting really good positive feedback from this. That it was very nice. They really enjoyed it. Great job. Good presentations. They enjoyed seeing this. Easier to come and get to than the meeting. I like the idea of more meetings like this. This was very helpful. So we're getting a lot of positive feedback on this.
I think it's great. And it was a great idea for the AAPC to start doing this. I think we're going to see a lot more virtual stuff with the AAPC with things that are going on today. We may even end up having to do our review class as a virtual review class if that comes to be. We can all take turns doing whatever we have to do to talk. So it might have to come to that at some point.
Right.
Maybe we can do a Zoom party for our Maymania.
Maybe we could. A pizza party.
Get dressed up and dance like they did for the prom.
That's right. We can all order pizza and have
We
pizza.
have like a giant wine party or something.
That's right.
There you go.
I like it.
Nobody drives anywhere.
That's right. Yeah, but you guys did a great job. Leanne, you always are an amazing presenter. It's wonderful. You know, and
Thank you, Gail.
Yeah.
I try.
Yeah, you're fantastic. And
it's all about the pictures.
yeah. Well, you haven't great little cohort with you, so she does awesome.
Yes.
I know, God forbid she moves out
That's
on me
right.
and gets her own place. I'm gonna have to move with her.
That's right. Yep. I do want to let you know I did.
Back home.
I talked to the girl at April Gardner just the other day because my students are starting to go do what they have to do for our class, and she is very anxious to start working with our students and is very willing to either do something herself or send somebody to us at some other point down the road. So just knowing that she finally has a name with a face and all that good stuff, she was excited to start working with us. So that's all good.
Well, awesome.
Mm-hmm.
And we would like to see more of the students that, if they're not registered with, and we're doing virtual meetings and stuff, that they are interested in, that they can share the links amongst themselves, or at least be able to, access that content.
What I'm doing today is recording the meeting. So I can,
awesome.
because they were supposed to go to, a meeting. Some of them weren't
Right.
able to attend, so I told them that I would do this meeting for them, and that way they could see it and put their 2 cents in, whatever they had to do for their project.
Great.
I told them it wasn't going to be the same, but I mean, they can still see the camaraderie that we have, amongst each other, that everybody is so willing to help each other out. This is the amazing part about working with the AAPC people. So
Yes, we are so trying.
mm-hmm. Yes. All right, well, I'm going to go and upload this, and I appreciate all you did, and thank you so much.
Okay, thank you so much, everybody who's participated. Susan, is there anything else that you'd like to say this evening before saying goodnight?
Just somebody said they would like to have every meeting this way, and I just wanted to say we can only do 2 meetings a year virtually.
Mm-hmm.
Although if it comes to the point where, we want to do something educationally without CEUs, we could, of course, do it this way. But we can only get CEUs from AAPC 2 times a year this way, just so everybody understands.
That may change, Susan.
Yeah, that might.
You're right, it may.
Yeah, I mean, it might be something that, but I like the idea of, twice a year. If we can't do that, and then, maybe that can take place during those meetings that we miss in the summer.
Right. And when I talked to them a couple weeks ago, that was something they hadn't even discussed yet.
Right.
But that may come up.
Mm-hmm. Yeah.
Okay, well, thank you,
Great job.
everybody, and stay safe.
Yeah, stay safe.
And be well, and see you soon.
See you soon. Bye-bye.
Thank you,
Bye, everybody.
ladies.
Thank you.
Bye, thanks.